Hi everyone, how are you doing? So, this time I'm gonna talk about lithium, something that I'm betting most of you guys have used before, and I want to talk to you about 5 things that you probably did not know about lithium. So, question number 1. What is lithium FDA approved for? And the options I'm going to give you are bipolar mania, bipolar maintenance, and bipolar depression. And the answer is these two. So bipolar mania and bipolar maintenance, lithium is FDA approved for. If you remember, for lamotrigine, we were talking about how it stabilizes from below, meaning that it's more effective in preventing episodes of depression than it is in preventing episodes of mania. Lithium is kind of the opposite. It stabilizes from above, meaning that it's better in preventing episodes of mania than it is in preventing episodes of depression. Having said that, as you know, a lot of people do use it for bipolar depression over off-label as well. But those are the two that is FDA approved for. Now, question number 2. What is the therapeutic serum concentrations of lithium? And this question has 2 answers. It has a short answer and a long answer. And I'm betting that you guys already know the short answer. The short answer is this one, 0.8 to 1.2. The way I memorize it is kind of like 1 plus minus 0.2. So that's very easy to remember. But it also has a long answer. And this here, let me first cover it and go part by part. Here, the long answer is it depends. So if there is an episode of mania, you will have a different target serum concentration than if you're using it for maintenance. If you're using it for mania, this is your goal, 1 to 1.5 serum level for lithium. But if you're using it for maintenance, I'm going to tell you the answer that I came up with, and then I'm going to tell you how I came up with it. This is the answer for if you're using it for maintenance. It's 0.6 to 1.2 if you're using it for maintenance. Now, I looked at 2 books for this one. This book, Stahl, you guys know it. In this book, which is the Pocket Handbook of Kaplan, so they have different answers. They both agree for mania. When it comes to mania, they both agree that the answer is 1 to 1.5. So a little bit higher than the usual serum levels that we have. But when it comes to maintenance, Stahl says 0.6 to 1.2. Kaplan, on the other hand, comes up with a lower dose. It says 0.4 to 0.8. So relatively low dose. And then Kaplan itself goes to say, well, if you stabilize at 0.4 to 0.6, you have almost twice the risk of relapse. Then maybe 0.4 to 0.6 is not a very good idea. But, so I did stick with 0.6 to 1.2 from Stahl. But I did make a note here for myself for my own use in the future. And then when we get to the next question, you will see why I felt like it's important to put it here for myself. And that is, I can consider going as low as 0.4 for maintenance if necessary. And I'm going to tell you in question 3 when it may be necessary. So it brings us to question 3, which is, what is the serum lithium level that after which there is no significant increase in risk of cardiac malformations in pregnant women who use lithium during pregnancy? Can you think of a lithium level that if you have that level or a lower level than that, then you can kind of think that you should most likely be safe. Can you think of a lithium level? Okay, I'm going to first tell you the answer, and then we are going to talk about where this answer has come from. So this is answer. This is the answer. So lithium levels, lithium serum levels lower than 0.64 is not significantly associated with cardiac malformations. So where this number come from? This number has come from this article. This is a 2020 article in American Journal of Psychiatry. This is a meta-analysis. I have written the citation for you below to go and find it, and I find it very interesting. Why do I find it very interesting? There are 3 reasons I find it very interesting. Number 1 is that this article, in a lot of circumstances, it compares patients who are on lithium with patients who are not on lithium and are suffering from affective disorders. So a lot of time the question is, okay, it's not fair to compare people who are on lithium with healthy controls. Because what if some of the problem is because they're already suffering from a disease that can affect the child. So a lot of times in this article, when it compares the patients who are on lithium with those who have affective disorders but are not on lithium, a lot of the differences are not statistically significant anymore. Like, for example, cardiac malformations, when they look into pregnancy in general, there is no statistically significant relationship anymore. When they do look at the first trimester, there is a statistically significant difference. But then that brings us to number 2, which I find very interesting, the number needed to harm versus number needed to treat. So among those who, even in the first trimester, when you look at the first trimester, when there's a significant difference, the number needed to harm is 83. In other words, you need to treat 83 women in their first trimester with lithium to get 1 extra case of cardiac abnormality. Number which, in my opinion, is relatively high, especially when you compare it to the number needed to treat, which is 3. Number needed to treat for prevention of relapse, postpartum relapse. So for every 3 women that you treat with lithium during their pregnancy, you get 1 person, you prevent 1 relapse. That and this is kind of like, to me, the message to me is that it's all about how important it is to talk about risks versus benefits and have that discussion with the patient and come up with an answer together, because it's not a one size fits all answer by no means. So that was interesting in the article for me. And then the last one was that they looked at it and they saw that if you have a lithium level lower than 0.64, there is no more a statistically significant increase in cardiac abnormalities, which brings us to the last one. If you remember, we talked about how you can go as low as 0.4. I will probably try to avoid lithium in the first trimester, because that's where all the risk is, and I will probably try to stay close to 0.6, because I know that 0.4 to 0.6 there is almost twice the risk of relapse. So that's my takeaway from the article and the books. So that is question number 3, lithium in pregnancy. What is the serum lithium level that you're shooting for? And question number 4, what are the medications that you look for in the patient's medication list when you're thinking of prescribing lithium? And what do you do about it? Next question. Can you think of a few medications? Can you name a few medications that you will look for? Let me give you the answer. So these are the answers, and I did write it in this way. Let me show it to you this way. Okay, the first group is diuretics. You guys probably already knew about them. And then, if you remember when we were talking about the Alzheimer's disease medications, duloxetine, and galantamine. I said that I like to think of exceptions because they're usually the easiest ones to remember. So I have exceptions here, and I'm going to tell you what I mean by that. So the very first question are the diuretics. Now, you guys probably know one of the diuretics that really causes a lot of problems. And those are, let me put it this way so that, yeah. And those are thiazides. So thiazides like hydrochlorothiazide, like chlorthalidone, those are the medications that are, you know, most of us have already heard about them. We have heard that you need to cut the dose of lithium in half because they really interact with with lithium in the kidneys and how they are excreted in the kidneys. So you need to do half the dose. There are two other medications that are two other groups rather that are affected. They kind of interact with lithium in the kidneys and they increase the lithium serum levels. They are not as notorious as thiazides, but they are important. So the potassium sparing ones and the ACE inhibitors. So the message to me is that I really need to look for these three medications. If there are thiazides, I should either think about avoiding them or should cut the dose of lithium in half. Now, there are one group of diuretics that they are the exception and they don't interact with lithium in no way whatsoever. And they are the ARBs, so like losartan and such. The interesting thing to me is that all of the other diuretics interact but in the opposite direction. Meaning that what? Meaning that they decrease serum lithium levels, which is something that I can work with. I'm not really worried and afraid of a decreased serum lithium level because you can always increase the dose. It's not toxic, that's fine. So all of the loop diuretics, acetazolamide, osmotic diuretics, all of them decrease serum lithium levels, which is something that I can work with. The three that I'm really scared of are the thiazides, the potassium sparing ones, and the ACE inhibitors. So that brings us to the next group, and that group is NSAIDs, as you guys probably thought of. You know, most of the common NSAIDs increase the serum lithium levels, but how about exceptions? There are two of them that don't do this, and those are aspirin and what was the name? I forgot myself. Solendac. Solendac is one that I hadn't heard a lot about, but it was very interesting to hear that aspirin and Solendac, those are the NSAIDs that don't increase serum lithium levels. Those are stuff to think about. I'm going to bring it here to you guys, aspirin and Solendac. And then the last group, which was interesting to me, it was not very clearly on my radar, are calcium channel blockers. Those are medications that can also be used for hypertension and can cause fatal neurotoxicity when they are used with lithium. So these were all medications that were very interesting to me when I was reading, and I tried to make a note for myself to keep them in my mind as I'm moving forward. So this is question number 4. And then let's go to the very last question, which is question number 5. And that is, while I was, since my PGY1, I always wondered what are the differences between different preparations of lithium and when do you prescribe one versus the other. And it took me a while to find the answers to those questions. So let's review what are the preparations of lithium. So there are 3 of them. There is the carbonate, there is the citrate, and there is the slow release version. And so the carbonate is the one that we usually prescribe. That's the capsule. It comes in 150, 300, and 600 milligrams. The citrate is actually the liquid form. and this is a typo. They usually come in 8 milliequivalent over 5 milliliters. They are usually prescribed either 5 or 10 milliliters. They are one reason that you may think of for prescribing a lithium citrate versus a lithium carbonate is if the patient has a lot of GI side effects, so like vomiting, stomach upset, diarrhea. Those are all reasons to think of citrate. Why? Because it has a lower likelihood of those side effects if somebody on carbonate has them. The other group are the slow release and the controlled release one, the 300 milligram slow release and 450 milligram, the controlled release one. That one is also good for reducing side effects because you will have lower peak serum levels as it gets released slowly in the body. The only thing to keep in mind for the slow release is that it has lactose in it. So if somebody is lactose intolerant, they may have diarrhea for different reasons on lithium, the slow release version. So that was pretty much it. Those are the 5 questions, and I hope that you learned something. Have a good one.